Greetings and welcome to this video on antibiotics in pregnancy. In this video, we'll discuss about the ICU and physician practical guide for giving an antibiotic in a pregnant woman. So we'll discuss about the safe drugs, the drugs to be avoided, the drug that should be used with caution. So this is Medicine Beyond Harrison. If you are new to this channel, do subscribe. Let's get started. The core principle, maternal sepsis kills both. So if maternal sepsis is not treated adequately, both mother and fetus do extremely poor. So adequate control of infection is the prime priority, but for that we need good antibiotics that does not harm the fetus also. So we have to always try to avoid maternal sepsis and treat it adequately. So most ICU workhorse antibiotics are actually safer. So if you consider beta-lactam, it is safer. The risk benefit ratio is almost always favors treating infection more than not treating it. So always try to treat an infection to avoid this unwanted complications like sepsis, fetal loss. And more than the drug that harms the fetus, it is the sepsis that itself harms the fetus. So physiological changes because of volume expansion and increased renal clearance, there is changes in the pharmacokinetics and dynamics of the drug. There is high volume of distribution and high renal clearance. So because of that reason, it may require dose optimization and monitoring. Yeah. So generally, safe drugs are like almost always considered safe as the beta lactams, penicillins, aminopenicillins, like ampicillins, amoxicillins, BLBLI combination, piperacillin-Tazobactam, then cephalosporins, ceftriaxone, cefepime, cephazolin, then carbapenem, meropenem, imipenem. Everything are actually safer in pregnancy. So these are very much safer drugs that can be given even in pregnant women. The other safe agents are like always astronam is very safe and limited evidence is there, so use with caution. Vancomycin, it's again a class 3 drug with you have to monitor its level as always in a even a non-pregnant adult male or female. You have to monitor its levels. There is high clearance in pregnancy that so that you need to give more dosage or more frequency dosage to achieve the target concentration or area under the curve. Have not watched that video on vancomycin, do go and watch so that how you know how to achieve this area under the curve. Then daptomycin is also considered safe during pregnancy. So for anaerobic coverage, you can go for metronidazole. It's a class B drug. Again, clindamycin is also very safe, and azithromycin is also safe for and as of now, we have covered all the most important commonly used antibiotics in even in an adult practice. Same for pregnant women. All these drugs are safe. So nitrofurantoin, it's safer in the first and second trimester. It's a class B, and during class 3, due to the risk of neonatal hemolytic anemia, it is avoided. Otherwise, it is safe for the mother. For the fetus, it can cause neonatal hemolytic anemia, hence avoided in the third trimester. So cautions, these are drugs that can be used with cautions only when the benefits outweigh the risk. The doxycycline, avoided beyond first trimester always. For first trimester, you can give it based on the risk and benefits ratio, where it can cause tooth discoloration, congenital defects. Newer evidence questions its risk now. Actually, you can nowadays few studies suggest that doxycycline is actually safer in pregnancy. So, it is a drug of choice again for anaplasmosis. So, always untreated disease is more than the drug risk always. So, can give drug when it is required to treat this some type of atypical infections when you can not use a macrolide. So for most atypical coverage, macrolides like azithromycin can be used and is also safe in pregnancy, especially for this anaplasmosis. Doxycycline is the drug of choice. So yeah, try to treat the disease more than being cautious for the drug risk. Linezolid again, there is a toxin suppression, and there is no proven heterogeneity, but limited data are there to reassure its effect on the fetus and maternal circuit. It has a reliable pharmacokinetics compared to vancomycin. It has excellent tissue penetration. So there is also high toxin suppression also. So it can be used in very severe cellulitis in that cases. So fluoroquinolones again, Cipro, Levo, Moxie, or all these can cause cartilage toxicity for fetus. And human data, there is no increased heterogeneity risk, but still use when clearly indicated and alternatives when it is inferior. Try to use this. Otherwise, always go for alternative drug. So always avoid. These are the not first line. The risk is always more than the benefit, whatever the reason you made give. So the first drug it is aminoglycosides. Even for adult medicine nowadays we don't use aminoglycosides. Even if used, only amikacin is given. For pregnant women, always avoid this aminoglycosides. It can cause fetal ototoxicity and possible nephrotoxicity also. Tobramycin, gentamicin, amikacin, short courses can be possible with monitoring, but always safer alternatives will exist for aminoglycoside, and go for the safer alternative. Don't go for this. So trimethoprim, sulfamethoxazole, always try to avoid. Even in second trimester also try to avoid. In first trimester it can cause major congenital malformation. In more than 32 weeks it can cause genital stress. In second trimester, the guidelines say that you can use with caution when the benefits outweigh the risk, but only if acceptable and there is no alternatives. If not, then try to avoid it. Practical risk stratification, like first trimester, it is almost the period of organogenesis. So avoid teratogens. Second trimester is the growth period. This is actually a safer window when all organs are generated. And the mass is just expanding. It's just a safer window. The third trimester, neonate is almost a surviving fetus. So it can cause neonatal toxicity like kernicterus, hemolysis. So try to avoid those drugs that can cause this. Gestational age matters as much as the drug also. So, empiric therapy for a peripartum shock. Nowadays, we prefer a PLBLA combination with Piperacillin-Tazobactam, plus or minus a gram-positive coverage that can cover a broad gram-negative anaerobes, coverage of MRSA and toxin suppression, and for both pregnancy is acceptable. So, this becomes the first line of choice if both these drugs are available. Pelvic source, anaerobic coverage is always needed. Group A streptococcus, very high risk of toxic shock syndrome, and toxin suppression is always desirable. So let's go for a linezolid. Clindamycin does not cause endotoxinemia suppression. So in these cases, go for a linezolid. So sepsis bundle, maternal first. So if you have a fever, hypothermia, tachycardia more than 110, MAP less than 65, fetal tachycardia, act early. Pregnancy masks sepsis. So always consider sepsis with a low threshold. Check for the saturation, circulation. Give 30 ml of per kg crystalloids, then IV antibiotics after taking the appropriate blood culture or urine culture. Source control retains products can be the source of infection, endometritis, abscess. So no antibiotic cures the dead tissue. Always remember that source control is as important as you give an appropriate antibiotic, and always remove the retained products, endometritis or an abscess if possible. So emergency delivery only if it improves the maternal outcomes and obstetric indication increase. It is often the secondary priority. Never delay maternal resuscitation for fetus. Common mistake is delaying antibiotics due to fetal fear. So try to avoid this major blunder. It is always the sepsis that can kill the fetus, not the drug per se. So choosing inferior agents to play safe, that is also a very big blunder. Ignoring trimester specific risk is again a big blunder. And forgetting pharmacokinetic changes and giving underdosing, it is also a big blunder. Appropriate dosing is always necessary. Treat the mother aggressively because the mother is not single during the time of pregnancy. She is a two. Both the child and the mother, both two lives are there. So safe drugs are always beta-lactam, clindamycin, azithromycin. You can use in caution vancomycin, linezolid, and fluoroquinolones and doxycycline with caution. Always avoid aminoglycosides, tetracycline, and cotrimoxazole in first and during term and first trimester. Now we'll discuss a bit more in detail about the pregnancy safe regimens based on the syndromic approach. So for urinary tract, for pneumonia, we'll go for a syndromic approach. The golden rule is treat maternal sepsis first. Use broad pregnancy compatible IV therapy. Then you can go and de-escalate. So we'll discuss about the clinical protocols as from the standard guidelines and the ECOG guidelines. Critical care and shock. When you don't know the source of septic shock, go for Vipras and linezolid. This is the best drug of choice. Linezolid, you should caution. It always suppresses the endotoxemia, which is a broad gram-negative coverage. It can also cover the anaerobes. MRSA coverage is also there. Linezolid toxin suppression is there to prevent toxic shock syndrome. When you suspect a group A streptococcus infection, toxic shock syndrome, this is the drug of choice. Vipras and linezolid. Linezolid or clindamycin requires to suppress the toxin production. Rapid source control is always essential. Clindamycin does not suppress the endotoxemia, but as well as linezolid, it can suppress the endotoxemia. For abdominal and pelvic source of infections, again, you can go for piptas and clindamycin for endometritis and septic abortion. Strong anaerobic coverage and gram-negative coverage is required. Add clindamycin if group A, streptococcus and toxic shock syndrome is suspected. Intra-abdominal or biliary, go for just Piperacillin-Tazobactam. There is more than enough. If not, then go for ceftriaxone and metronidazole. Always avoid metronidazole during the first trimester if possible. It has excellent gram-negative and anaerobic coverage. For respiratory sources, again, ceftriaxone is mostly sufficient if you suspect an atypical infection, or always add azithromycin, or you can go for doxycycline and use doxycycline with caution. So atypical coverage is required. Doxycycline is accepted if necessary. For aspiration pneumonia, ampicillin-sulbactam becomes a drug of choice. It targets the oral anaerobes and the gram-negatives. It is a pregnancy-safe drug. You can use ampicillin-sulbactam. Urinary infection, ceftriaxone is always preferred. If not, then go for piperacillin-tazobactam for severe UTI. It has strong enterobacterial coverage. Avoid cotrimoxazole in early or late pregnancy. For severe skin and soft tissue infection, cephalosporin plus or minus linezolid. Prefer beta-lactam for MSSA. Add linezolid if MRSA or group A streptococcus concern is there. So specific pathogens, listeria can cause meningitis during pregnancy and cause sepsis. In that cases, go for ampicillin plus or minus gentamicin. Ampicillin is the drug of choice for listeria, and gentamicin short course only if necessary. The suspected MRSA bacteremia, you can go for vancomycin or linezolid. So linezolid favored if AKA risk or need toxic suppression, and to monitor vancomycin levels closely. Do not miss dosing, so do not underdose. Pregnancy physiology is there is increased volume of distribution, increased renal clearance. So standard doses may fail. Always keep this in the back of the mind while treating. So avoid delays for cultures. Draw them before giving an antibiotic. Prefer beta-lactams whenever possible. Reserve avoid drugs for the last resort. Reassess in 24 to 48 hours. De-escalate once the source is known. The bottom line, choose the safest effective regimen by the source. Do not underdose, do not play safe, do not consider the fetal loss where will be there with antibiotics. Do not do that. Maternal life is always very important. So we learned a lot in this video of how to choose a maternal antibiotic. Maternal stabilization saves the fetus. So if you like this video and you've come this far, do subscribe to this channel. We'll in the next video in this series of antibiotics and pregnancy specific drugs, and we'll go in detail about the other antibiotics also in the upcoming slides. If you're first time to this channel, do subscribe. This is Medicine Beyond Harrison's. Thank you for watching.